Good morning, everyone. Thank you for joining us for the Medical Board of California quarterly board meeting. While this meeting is being conducted with participating board members and staff in the meeting location, this meeting is being streamed interactively using WebEx to allow for remote public comment in the same manner as recent meetings. Public comments for those who wish to speak will be heard for each agenda item from individuals attending in person and remotely. To be ready for remote public comment, we ask that you please ensure your comments can be heard clearly by being connected to the audio of this meeting through the proper method. If you're having difficulty hearing the audio of this meeting, it could be because the device you're connecting with has bandwidth limitations. If you do have difficulty hearing the audio of this meeting using your device, please click the ellipsis button at the bottom of the WebEx application or the audio and video menu item at the top of the WebEx application and then select Switch Audio. You will see an option to call in and will be provided with a telephone number, access code, and an attendee ID that can be used to connect to the meeting audio via phone. Using the information provided, it will automatically disconnect your device's audio and connect your phone to the name you joined the meeting with. By using this method, if you are having audio problems with your device, this will allow you to still participate and hear the audio of the board meeting. Please see the View Additional Meeting Information link on the first page of the meeting agenda item for more information on connecting to the meeting and accessing meeting materials. Thank you, Dr. Yip. You can now start the meeting.
Well, good morning, everyone. It's a tight squeeze up here. I'd like to first ask us to all turn our devices to silent. You may notice that board members will be accessing their laptops, phones, or other devices during the meeting. They are using these devices to access board meeting materials that are in electronic format. If you are a member of the media and you require assistance or information, please see Aaron Bone. Aaron, if you could identify yourself. This is an official business meeting of the Medical Board of California, and disruptions of the board's business will not be tolerated. Government Code Section 11126.5 allows the board to remove people who willfully interrupt a meeting and to clear a room if order cannot be restored by removing or muting the disruptive people. We will have a designated time on the agenda for public comment on items not on the agenda, and we will ask for public comment on all agenda items. The board welcomes public comment on any item on the agenda, and it is the board's intent to ask for public comments prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please raise your hand or come forward and you will be recognized. This meeting is also being streamed via WebEx. Individuals attending the meeting remotely via WebEx will have an opportunity to provide public comment and will be assisted by the host who will be facilitating the WebEx meeting. During each agenda item, the host moderating this WebEx event will activate the hand raising and Q&A features of WebEx and will ask anyone wishing to make a public comment to indicate so by raising their hand or by entering yes in the Q&A window. The host will then call on individuals who indicated they wish to make public comments by the name provided by the individual, which may be a pseudonym. When called upon, the host will unmute the microphone of the individual and they will have 3 minutes to make their public comment, but this time period may be reduced depending on the number of people who wish to speak so that more people may be heard. The host will audibly announce when 30 seconds remain to conclude the public comment. After the individual's time for public comment has lapsed, the individual will be placed back on mute, and only one public comment per agenda item is allowed per attendee. During agenda item 2, public comments on items not on the agenda, the board has limited the total public comment period for individuals to 40 minutes. Therefore, after 40 minutes, no further comments will be accepted. During public comment on any other agenda item, 20 minutes will be allowed for the comment period. After 20 minutes, no further comments will be accepted. Each person will be limited to 3 minutes per agenda item. I'd like to remind all speakers to please stay on topic and keep your comments to the allotted time or less. Today's meeting will be run according to the Open Meeting Act as required by law, and we plan to end today by 5 p.m. With that, I would like to call this meeting to order. I think it's about 10:05 a.m. And Ms. Struther, would you please call the roll?
Dr. Ayala Rodriguez.
Here.
Mr. Arkatov. Ms. Chung.
I'm here.
Dr. Mahmood.
Yes.
Ms. Remke.
Here.
Dr. Solis.
Here.
Dr. Thorpe.
Here.
Dr. Tolbert.
Here.
Ms. Torres.
Present.
Dr. Sai.
Here.
Mr. Watkins. Dr. Yip.
Yeah.
Ms. Lawson.
Here. Thank you. A quorum is present. And I would like to again remind members that we will be taking a roll call vote on all action items. We are moving on to agenda item 2, public comments on items not on the agenda. Before I ask for public comments, I would ask individuals making comments to not discuss any pending complaints, pending license applications, or pending disciplinary actions that may come before the board for a decision. Such discussions are considered ex parte communications, as they could provide information to the members that is outside of the record in violation of the Administrative Procedure Act. Therefore, such discussions could create a conflict and can lead to a board decision being challenged in Superior Court. The board can receive comments regarding the board's processes in general, but it cannot receive comments on specific case circumstances where the decision is still pending. In addition, the board requests the public to address the board as a whole and not individual members. And please be aware that public comment during this agenda item should provide information to the board members and is not a discussion between the board members and the public. The only action that board members can take is to listen to comments and decide whether they'd like a future agenda item on the topic. No other action can be taken on these items at this meeting. Though this may seem at times like the board members are not being responsive, following these guidelines is critical to ensure the rules of the Open Meeting Act are followed and to avoid compromising the speaker's goals or the board's mission. If you'd like to comment on an agenda item, please do wait until we get to that agenda item. Comments at this time are only for items that are not on the agenda. And please do limit your comments to 3 minutes or less. First, are there any comments from those present in the hearing room? Please come forward.
But, okay, now you can hear me. Good morning. My name is Susanna Zarajski. You've heard from me at all of your quarterly board meetings this year. I'm the citizen sponsor of Assembly Bill 3119, which passed last year unanimously by the Assembly, the Senate, and it was signed in by the governor to add long COVID medical education to the continuing education program, not just for doctors, but also for osteopaths, physician assistants, and nurse practitioners. So far, this board has not brought AB 3119 to your legislative agenda, despite my many requests. People have written to the board to ask you to add it to your agenda, and you have failed to do so. I have come several times by video explaining to you the statistics about how many people have long COVID, but apparently that didn't make a difference to any of you. So there are people with long COVID who can't get out of bed. I have long COVID, but obviously I'm here. I was able to drive myself here. When I had long COVID, when I first had long COVID, I could not find any doctors who could treat me. Stanford had a 6-month wait. I was not going to be laying in bed for 6 months waiting to get to Stanford. Other doctors had no idea what to do with me. There are still people who have long COVID. There's still people getting COVID. Even though we are not in the pandemic, long COVID still exists. People can't work. People can't take care of their kids. People can't go to school. And doctors aren't trained in what helps people with long COVID. And I think it's a shame that this medical board is subverting the democratic process by not bringing AB 3119 to be discussed during one of your board meetings. This was passed, like I said, by the Assembly and the Senate. It's very hard to get them to agree on anything, but they did, and so did our governor. And California was one of the first states to develop lockdowns and restrictions during the pandemic. And I don't know why this medical board is deciding to not listen to the people, not listen to the legislators, and not arm your doctors with what they need to learn to help people like me who have long COVID. We're in a place right now in this country where people don't believe in the public health system. They don't believe in politicians, but they're still sick. And if you don't want to discuss AB 3119, then please come up with an alternative about how the California Medical Board wants the doctors in California to learn about what supplements, treatments, medications help people with long COVID. There's some things that are as simple as allergy medications that happen to have another effect that help people with long COVID. It didn't help me, but it can help other people. For me, it was a special type of magnesium that helped me sleep through the night and gave me energy in the morning. I would not have figured that out if I hadn't found somebody who could direct me. And if you're doctors and you have patients who are suffering, you want to help them.
Please conclude.
So Please bring AB 3119 to your agenda for the next quarterly meeting. Thank you.
Thank you for your public comment. Are there any other commenters in the hearing room? All right, seeing none, we will open it up on WebEx.
Yes, if you'd like to make a remote public comment, please do so by raising your hand or just typing anything in that Q&A window. It doesn't need to be your entire question. Just let me know you'd like to make a public comment and we'll get you called upon. First up here, we have Rob Gordon. Rob, you should be receiving that prompt.
Are you able to hear me?
We can, Rob. Please go ahead.
Yeah. Hi, my name is Rob Gordon. About 5 years ago, or before that, about 8 years ago, I was correctly diagnosed and successfully treated for ADHD by Family Health Care Centers of San Diego, which is a federally qualified health center. Later, the decision was made to criminalize that successful program in retaliation for my complaining to the Medical Board of California by two physicians there. Apparently, I'm not allowed to mention their name, but let me start here by I've done some really extensive research, and let me follow on with the last person who could not get an agenda item. You hear this meeting starts the same way every time. They say, we can't do anything about pending cases, but they take 3 years to process a pending case, just to reject it, or a year to reject it, or whatever. They always say the same thing. The only thing the board can do is consider what you say for future agenda items. I've done an analysis. That has never happened, at least not in the past 4 years. They've never done it. They've never done it. So they are being untruthful when they say we can consider future agenda items. In fact, they have never even done it. Only once or twice have they done it for their own items. So they're finding things out by a different process. At the last meeting, I was censored. I went on yesterday to hear some of my comments. The vast majority of things I said was censored. I waited 5 years to say what I wanted to say, and I was censored. So this is what you call performative justice or performative governance. It's performance. It is not real. It is fake. They are not wasting your time. When it's systematic, it is not a waste of time. They are stealing your time. They are using you to justify their existence. And I'm part of that. Just by participating, they are using us. I take censorship very seriously. I take you don't have any rights at all in this system. You lose, especially if you're talking about mental health issues, you lose every right you had as an American. Medical records are often falsified. One of the participants at the last meeting said that they believe medical records are the holy word of the prophets that are never altered. If you get a condition, you have it for life. So this is bogus. I'm going to be issuing more Freedom of Information Acts or public records requests. I take those extremely seriously. I hope UC San Diego Health learned that. I'll be discussing this with Dr. Tolbert on Twitter. I will also be reaching out to the anti-vax community. I am not an anti-vax person, but as I said last time, it's not just patients that are getting screwed by this. Doctors are getting screwed as well. This is serious.
Rob, please.
I'm done. I mean, I have hours I could talk about this, but people have to know that this is performative governance. This is not real. This is kind of designed.
Thank you, Rob. Sorry about that. Next up here, we have Marion Hollingsworth. Marion, you should be receiving that prompt.
Okay, can you hear me?
We can, Marion. Please go
Okay,
ahead.
thank you so much. Good morning, I'm Marion Hollingsworth, patient safety advocate. I would like the medical board to revisit the idea of having a public committee similar to what has been a staple for the California Department of Public Health for years. They meet quarterly and include public members and medical professionals. During Ms. Lawson's first term as medical board president, I proposed having a public committee for this board to give feedback, offer ideas for outreach, and regularly attend meetings in person. If you remember, this idea was received positively, and there was talk about making the idea for this committee a reality. That hasn't happened yet, so I'm asking the board to reconsider this so the committee would actually be put in place. Also, I have suggested a number of times to occasionally hold one day of the quarterly meeting, either in the evening or on a Saturday, so that working consumers can attend without missing work. Some workplaces don't allow employees to listen in to the quarterly meetings, so they can jump in on the phone at the right time to make a comment. Having a meeting in the evening or a Saturday occasionally, or at least a couple times a year, would help consumers attend these meetings to voice their concerns. And finally, I back the previous speaker's request to address the issue of long COVID. I am taking care of a family member who has had long COVID since long before the vaccines were available. Most doctors have no idea how to treat it or even how to address it. Please bring AB 3119 to the board to be discussed. Thank you.
Thank you very much for your public comment. Anyone else would like to make a public comment? Please do so by raising your hand or typing something in that Q&A window. Give anyone else a few more seconds to queue up. This time, President Lawson, I'm not seeing any additional requests.
Thank you, Sean. Any further public comments from those in the room? All right, seeing none, we will move on to agenda item 3, approval of minutes from the last board meeting. And just as a reminder, minutes are a summary and a record of the votes that were taken, but the full recorded meeting is posted on the board's website. Members, are there any corrections to the August 21st, 22nd, 2025 board meeting minutes?
I just had a quick question. The meeting minutes, I was going through some of the minutes for November last year and February this year. And, you know, it's either over edited because some of the notes that I have didn't align with what I heard on the recording. And I'm just wondering, what's our process of editing the minutes per section? It seems like it's over edited. And I've listened to it twice, so that's
Wait,
why I didn't even get to today's ones. But
Mr.
I'll
Watkins,
point it out.
just to clarify, you're talking about the recorded version, the
The
video?
recorded version, yes.
And the question is, are those edited?
Yes.
Okay. I don't know the answer. Ms. Webb, do you?
The body of the meeting, the recording is not edited.
So there's a section. So there's a discussion section. That is the full extent of the entire discussion.
Yes.
Okay.
Any other questions or comments about the minutes?
I'll move to approve the minutes.
Great, thank you. Dr. Sy?
Second.
Thank you, Dr. Yip. All right, we have a motion and a second. Are there any public comments from those present in the hearing room? Are there any public comments on WebEx?
If you'd like to make a public comment on agenda item number 3, please do so by raising your hand or typing anything into that Q&A window. First up here, we have Rob Gordon. Rob, you should be receiving that prompt.
Yeah, thank you. Absolutely. I have some questions about the minutes. I had never looked at them until last night. I looked at an old one, and they gave a summary of each individual's comments in the meeting that Terry Webb censored last month or last quarter. All it says now is the name of the participants. That's all. That's nothing. That doesn't say a thing about what they participated. I'm going to be setting up a resource on abolishmbc.org because I believe this organization should now be abolished. It cannot be reformed, impervious reform. But the minutes are absolutely bogus. Nobody should approve those minutes. They don't say anything about the participants. They only say things about yourselves. The participants are the important ones. That's the reason for having this meeting in the first place. So do not vote to approve these minutes. Read them first and realize, as far as the participants are concerned, they say nothing. They're not even minutes, so they're no good. This is just ridiculous. But do not approve these minutes. That's all I have to say. Go ahead.
Thank you for your public comment. At this time, President Lawson, I don't see any additional requests.
Thank you. Are there any additional comments in the room? All right, seeing none, Ms. Struther, if you could please perform the roll call vote.
Dr. Ayala Rodriguez,
Yes.
Mr. Arkatov,
Yes.
Ms. Chung, Dr. Mahmood,
Yes.
Ms. Rimke,
Yes.
Dr. Solis,
Yes.
Dr. Thorpe,
Yes.
Dr. Tolbert,
Yes.
Ms. Torres,
Yes.
Dr. Sy,
Yes.
Mr. Watkins, Dr. Yip,
Yes.
Ms. Lawson.
Yes. That motion carries. We will move on to agenda item 4, the president's report. I just have a few brief items. First of all, I wanted to wish everyone happy holidays, and I hope everyone had a very happy Thanksgiving last week. I wanted to, just as a point of personal privilege, I guess, extend my gratitude, to all members of the medical profession who spend their Thanksgivings working. I've had the unfortunate opportunity to spend a lot of time in hospitals and in doctors' offices over the past week, and with one of my kids. And I will tell you that the people who work, whether it's doctors or nurses or anyone in the allied health professions over the holidays, are just incredible people. So, excuse me, I apologize. All right, now on to something happy. I'd like to congratulate our colleague Annie Chung. She was honored last night at an event I was unable to attend, unfortunately. She was honored as one of just a handful of San Franciscans of the year at a really special event. So congratulations, Annie, on all of your extraordinary achievements. You are very welcome. I know that the Bay Area community and San Francisco community was very excited to recognize and celebrate you last night at that special event. It's really an extraordinary event every year. And so congratulations again to you. I loved seeing in the Nob Hill Gazette and in the other publication, the pictures they did of you and the nice write-up. So congratulations again, and thank you for your tremendous service over all of these years, not just to the medical board, but to the broader Bay Area and California community. And lastly, I wanted to introduce our newest board member, Dr. Tolbert, who was unable to join us. It is technically his first meeting because I think you were appointed 2 days before it or something. We are really glad to have you as part of the board. Among many other accomplishments, Dr. Tolbert is a clinical assistant professor of emergency medicine at UC San Diego's School of Medicine. And I'd love to invite you to say a few words if you'd like. No pressure.
None at all. First of all, thank you to the board and to the CA for having me here today. It's a privilege to be on this board, and I look forward to serving the people of California. Thank you.
Thank you. We're thrilled to have you part of this board. And I, again, I guess as a point of personal privilege, would like to recognize that I think we have a full complement of board members at this board meeting, which has been rare. So I thank you to the governor's appointments team and to the governor and to all of the appointing authorities to having a full board in place. We're excited about that. Moving right along, just to report on contacts with interested parties. I don't have any specific contacts to report, but I continued, as I always do, to meet with those who, request meetings or forward communications that come directly to me, to our professional staff. Are there any questions or comments from members on any part of the president's report, or do any members have any interested party communications to report? Dr. Yep.
I attend the FSMB Ethics and Professional Business meeting on October 15, 2025. 65% of the physicians are employed. So there's a trend for physicians to be unionized, and they may have the right to strike. So we talk about the scenario in the future. An interesting topic that I probably plan to get some speaker in the future to follow that trend. Thank you.
Thank you. Mr. Watkins?
Yeah, just like the board chair, just the usual talking to patient advocates, quick conversation with NBC. That's it. Just by the way stuff.
Any additional communications? And just as a reminder, we do ask to the extent there are any communications that you've had with interested parties that are relevant to a matter on our current agenda, that you just report those during those agenda items as well. Any other comments? Any public comments in the hearing room? Are there any public comments on WebEx?
If you'd like to make a public comment for agenda item number 4, please do so by raising your hand, typing anything in that Q&A window. First up here, we have Michelle Montserrat Ramos. Should be receiving that prompt. Morning, Michelle.
Good morning. I am Michelle Montserrat Ramos, and I'm with Consumer Watchdog. We would like to welcome Dr. Tolbert and Dr. Solis to the board. I would like to take the opportunity to introduce myself. I began attending and participating in these meetings 18 years ago as a national and state advocate. I now lead a team of volunteer patient advocates with Consumer Watchdog. I work with families across the state whose family members have either died tragically due to preventable medical negligence or who survived extreme harm. I am one of those families. I've lost a couple of family members to medical negligence, but in this forum, I focus on the death of my husband-to-be, Lloyd Montserrat, who died tragically following elective surgery performed by a surgeon with an addiction to crack cocaine. The board knew about this doctor's long arrest record for possession of crack cocaine and for prostitution. They knew of the other victims and the malpractice judgments, but none of this information was available to Lloyd nor I, and it cost Lloyd his life. Due to this incredibly tragic loss, not just to our family, but to a political community, I stepped forward as an advocate and tried to work with this board. I was one of 3 people that moved a prior medical board to protect consumers and abolish the former diversion program. My testimony at a diversion hearing at the Capitol led to the creation of SB 1441, the Uniform Standards for Substance Abusing Healthcare Professionals in California. I say all of this because I want you to understand how courageous these families are that keep coming to these board meetings and presenting ideas to this board for change. I'm asking you to listen to the public and hear our voices. As a team, we have presented issues and fought for legislation that has helped bring some transparency to this board. And this board has been lauded for these projects by our state senators. We are here to work with you to improve the board's enforcement processes and the healthcare system at large. We look forward to working with you. Thank you.
Thank you for your public comment, Michelle. Next up here, we have Rob Gordon. Rob, you should be receiving that prompt.
Yeah, I went to the censored meeting in San Diego, specifically, or not, partly to address Dr. Tolbert and my experience at UC San Diego Health. I want to emphasize the critical importance of responding to every California public records request. That is the only right we have. And UC San Diego Health completely ignored mine. I wanted to complain. I complained to a psychiatrist there about the first person I complained to, a pathological liar and con man who fraudulently claimed to be my psychiatrist, who I have never even met outside of a 10-minute online meeting that was non-consensual. I thought I was discussing continuity
Gordon?
of care. In retaliation.
Comments on the president's report?
I'm sorry?
Do you have comments on the president's report?
The president hasn't made his report yet.
Yeah, she has.
Oh, yes, about the censorship and the importance of
No.
the I only have another sentence to make. Can I please
All right,
make
please
it?
conclude.
Okay, I want to emphasize that retaliation is their way of being. It is baked into the system, and UC San Diego Health should not be doing that. Respond to every single public records request you have. Thank you.
Thank you for your public comment. At this time, I don't see any additional requests in queue.
Thanks, Sean. Any public commenters in the room? Okay, seeing none, we will move on to agenda item 5, executive management reports. Again, a reminder, we are going to take all questions and comments after the conclusion of all of the reports. Sean, I think you are going to start us off.
Morning, everyone. Thank you for having us to give you a little technology update here real quick. In terms of our staffing updates, 2 positions are close to being filled. So our information system branch, much like the board panel here, will be pretty full here pretty soon. Very excited about that. It's been a couple of years since we've had all the positions filled. Our infrastructure updates are going well. We've completed all the switch and access point rollouts to modernize our offices, including the HQAU offices throughout the state. HQAU's received all new laptops, part of a 5-year refresh that we do, and we'll be working with medical board staff next to do that, hopefully starting here before the end of the year. As for the complaint tracking system update, testing is going well. The demo we gave you guys at the last board meeting, everything's still looking the way it was demoed that time. We're focusing now on the clear language definitions of those activity codes and how they appear to the users and things like that, looking at them not just in the granular individual code level, but as an entire picture. So still doing all that testing and again, hope to launch that early in 2026. As for our iOS application update, we've switched up. When we started the project, Apple hadn't released iOS 26. Now they have, and it's changed a lot of the look and feel of the thing, and we wanted to make sure that it wasn't obsolete right away. So we made some changes to support iOS 26. That will support iPhones all the way back to iPhone 11, but it's still compatible with iOS 17 and 18, meaning it'll go back all the way to an iPhone XR. It was released back in 2018, I believe. So testing's all completed there. We're submitting it to Apple right now. Hope to have that out here by the end of the year. Just a reminder, the upgrade from our current app is it will just do push notifications, just so you don't have to have the app running in the foreground all the time to receive those notifications, and some look and feel updates and things like that. New to our update list here is the Consultant Expert Management application. We call it SEMA. We are doing some enhancements there to reflect the new training processes that the Enforcement Expert Training Unit has put into place to make sure experts are completing their training to get the higher hourly rates and things like that. Specialties get higher rates in there as well. And we're revamping the security in the application to allow users from the DCA network to be able to access it as well too. That could be people in DOI or even other boards as well if we'd like to. The automation for part of the renewal contract or the automation for renewal contracts for these experts will also be handled automatically, so that it frees up more of the analysts' times to be assigning cases and doing things like that instead of just sending emails and expediting contracts for reviewers that are renewing. So while there's no public access to that system, it will help to free up analyst time. So we're working on that. As for the doc system update, you can see some usage statistics in there. What's important to know, we added in September 2 new document types, the program status update form and the enrollment form for licensees. Those are forms already available for applicants, but now they can be uploaded for licensees as well too. Those were added in September. You can see the yearly trends for applicants, that big spike in July, kind of repeating year over year now, and we're starting to see a trend like that form with licensee documents too. So use of the system is ongoing. So as for the volunteer physician registry update, a small increase in experts, only 6 experts I believe added since last time. So we're still working on getting the word out there. It could just be that we've reached saturation point with experts or with volunteers accessing that system, but we'll continue to advertise that system and let physicians out there know it's available. As far for the HCI survey update, AB 91 was signed into law about in October with an effective date of January 1st, 2028. The effective date changed on that. It was initially going to be 2026, but I believe there was some delayed implementation added to that to change statewide in all data collection how race and ethnicity is gathered. So that will affect our survey, and the fact that we have to change some of the questions on there to add some new options for race and ethnicity. HCI has also asked for changes to the responses in the sexual orientation and gender identity questions, so we'll be making those at the same time. We expect to implement these changes sometime later in 2026 or early 2027, but certainly before that effective date of January 1st, 2028. We'll be coordinating that with DCA. We'll make their updates at the same time for all of the other non-allied health boards that they host the survey for. As far as our Breeze online complaint form redesign, the code from the vendor is available. We're waiting to have some meetings with the DCAOIS staff to configure that code now. They're busy with legislation, all the new legislation going into Breeze for not just our board, but all the other boards and bureaus under the Department of Consumer Affairs. So we expect those meetings to pick up in January and hopefully see that release of the new complaint form redesign early in 2026. Our electronic only renewal notice project, you can see there's some of the usage trends there. We've got up to 95 to 96% of licensees renewing online without having to do any sort of paper involvement, which is really great. They might contact the help desk here and there for a password reset or something like that, but those are easy fixes. That's the highest level that's ever been. Some weird fluctuations there in August and September, I think, like that. People still just kind of getting used to it, but it seems like now in the last couple of months, More than 2/3 of licensees were renewing more than 120 days prior to their expiration date, meaning that they're not having to pause practice or anything like that because they missed the renewal notice or anything like that. So that 2/3 number renewing that early is a very high number, highest we've ever seen. So seems to be working out well. And then finally, the print yourself wallet cards update. It's just for informational there, but we still see adoption of licensees printing those cards, presumably giving them to their, hospital or for their credentialing and stuff like that. But just see continual usage of that system. So that's good to see everyone's adopting that. So thank you very much. I think I'll turn it over to Doug next.
Good morning, everyone. I'm here to provide a program update for licensing. In Q1, we received 2,500 license applications. We also issued a total of 3,711 licenses. For our licensing program, we continue to work to improve the applicant's experience. Recent updates include some form updates. The duplicate fictitious name permit and application to restore license to active were reformatted, and unnecessary fields such as social security number, address, telephone, email, certain certification sections were removed. Also, for our timeline of activities form, it now clearly requires detailed activity descriptions inside and outside of California. Additionally, the certification of completion of postgraduate training form was updated to reduce unnecessary documentation for maternity and parental leave, and to better capture performance improvement or remediation plans related to disciplinary actions. The research form has been discontinued, and all references removed from the website included related questions and other forms. Additional process improvements, applicants without a social security number or an I-10 can now upload deficiency items electronically after receiving a BREEZE PIN number. Also, a new electronic quality assurance review process replaces paper reviews, which improves speed and accuracy for our process. Docs update. We continue to work with training programs and medical schools to update docs registration forms to allow broader acceptance of digital signatures types. Since its inception, docs has been very effective. As of November 1st, 2025, nearly 150,000 documents have been uploaded through docs, and that's for 33,891 applicants. For our webmaster, the licensed webmaster responded to 2,754 emails in Q1. The most common topics during this quarter were license updates, initial renewals, and fictitious name permit questions. For our outreach in Q1, the board conducted 12 outreach activities, 11 in person, 1 virtual. Some of the common topics discussed included the new ECFMG requirements for Canadian medical school graduates, PTL requirements, and first and second time renewal requirements. For our call center in Q1, the Consumer Information Unit received 17,676 calls with an average wait time of only 2 minutes. The top 3 topics discussed during this quarter were renewal assistance, complaint questions, and application questions. That's the update from licensing. I'll turn it over to enforcement.
Good morning, members. Charlene Smith, Chief of Enforcement. Happy to see you all today. Providing an update over the enforcement program for you. For the first quarter of the 25-26 fiscal year, CCU staff have been meeting the timeline mandated for complaint initiation. Management is looking at process improvements to bring that down. The mandate is 10 days. We're averaging 9 days. We don't want to see that continue, getting close. So we're looking at business process changes to bring that down and decrease that overall aging. CCU staff is at processing complaints within the average of 180 days. We are also looking at business process improvements, some of which have contributed to the increase. We're trying to, Mr. Varghese explained at last board meeting that we're trying to go paperless in CCU. I don't know that we'll ever be fully paperless because not everyone has an opportunity to get to a computer and, some people need assistance. However, overall, we can work to make those improvements. So we're looking at that and other avenues, but there are some other factors that we have no control over that do drive up that aging, such as having to request additional information and delays in receiving the information that's necessary. Problems obtaining authorization forms, which are necessary for us to contact the subject physicians or request medical records. So we're looking at these changes and trying to keep them under control and get things back on track because we're concerned about the aging overall for consumers and the people that are relying on us to review their complaints. In some instances, we also do have to subpoena records. That can also add to our aging for our complaints as well. So for CCU, that's the update for the complainant liaison unit. As you all may recall, this was implemented through legislation, and the unit was staffed in January. From January 1st through November 13th of this year, 1,532 complaints have been referred to the complainant liaison unit, and to date, 1,258 offers for interviews were sent. There are 78 of those that are pending responses. 63 interviews were offered, 8 interviews were scheduled, 44 interviews were declined, and 856 interviews were conducted. And then there were some 287 that we did not receive a response. And I think this speaks to the numbers showing how many interviews are conducted is huge. And the patient advocates were very, instrumental in helping to get this legislation and get this change in. And we're very excited to see the fruits of that and how that is improving that interaction and, having them get a little, not feeling as though they're not being heard, because we cannot close a quality of care complaint within our jurisdiction if we have a source without offering them an interview. And in some cases, we do learn information that hadn't previously been known. So that offers another route for that to go, more review to be conducted. So we're very pleased with the unit. We're pleased with the results to date, and I anticipate that we'll continue to see great results with the responses. Going to our expert and consultant program, we're always recruiting. We can never have too many reviewers because, at any given time, somebody could be on vacation, somebody could be sick, So, and there are a lot of doctors, there are a lot of complaints, and we need these reviewers greatly. They make or break our cases. So, where we've done some updates, management worked with ISB to update the expert reviewer program page, give a little refresh, streamline the content, remove some outdated information. That includes the licensed midwives information. And as Sean mentioned, his technology updates, we're very excited and happy to be collaborating with ISB to work on enhancements and improvements, a refresh of the consultant expert management application that we use for the consultant and expert program. It is not only used in-house, but also externally, and it's very vital, and we're able to get some great updates in there that are long overdue, and it's going to be beneficial for all that utilize that database. The Complainant Investigation Office between July 1st and September 30th closed 60 complaints in their unit. They transmitted 39 cases to the Attorney General's office. That was 19 criminal convictions, 12 malpractice cases, 2 vaccination exemptions, and 6 petitions for reinstatement. In DCU, the Disciplinary Coordination Unit, management worked with staff to reduce the pending caseload and aging of the out-of-state cases. We are very proud of the work that the staff and management have done to decrease that from the caseload from 406 to 137. And we've also implemented process changes to prioritize things and keep a better check on that, so we avoid this in the future. In probation, as of October 1st, there are 560 licensees currently on probation. In the first quarter of fiscal year 25-26, 25 licensees were placed on probation, 5 probationary licenses were issued, 2 licensees were placed on probation with suspension, 14 licensees successfully completed their probation, and 8 probationers surrendered their licenses while on probation. There were 9 citations issued for violations of probation, 3 cease practice orders issued for probation violations, 4 petitions to revoke probation filed, and 3 accusations petitions to revoke probation were filed. For the probationers who surrendered, the 9, the majority were that they either retired or they were unable to satisfy the requirements of their probation. Finally, we are so pleased to be have implemented the collaborative process with the Health Quality Investigation Unit and Health Quality Enforcement Agency at the Attorney General's office. It's been a long process. There's been lots of discussions, meetings, and we're so glad to have this. This was launched November 1st, so we're very pleased with that and happy to be working together to make our enforcement process even better. That concludes my report.
Thank you. I think we are moving on to Reggie's report.
Thank you, Madam President, and members of the board. This is my brief report of admin activities since our last board meeting through November 19 of 2025. So my report actually starts board meeting material BRD 5D as marked at the bottom of the page. The board staff and myself met with board leadership and other members of the board regularly on various topics and with updates, and also weekly and bi-weekly meetings with HQIU and Attorney General's office, staff, and other organizations listed in my report there. With particular mention to Ms. Patricia Irving and Mr. Monty Goddard, both members of the National Campaign to Protect People in Pain in relation to a future project. Moving on to staffing update. As of November 1, board's current vacancy rate is 12.69. We continue to actively recruit externally and provide promotional opportunity to our staff. It is worth noticing that as of January 1, 2026, that is next month, the board will be eliminating 5 vacant positions that have been designated for elimination as part of the 2024 Budget Act. Now, moving on to the exciting part, the budget update. For the budget update, please refer to page BRD 5D4. That is a fund condition and projection report for the period closed fiscal month 3, that is September 2025. So, here, the fiscal discipline and improved financial performance continued into end of last fiscal year ending June 30, 2025. Thanks to higher than anticipated revenue, including reimbursements and lower actual expenditures compared with projections, the board was able to repay all outstanding loan obligations, eliminating future interest expense tied to those loans. This disciplined approach to revenue collection, expenditure control, and debt repayment has significantly improved the fund condition, reducing the financial risk and increasing flexibility increasing flexibility for future years. When I say the financial discipline, it is focused on 4 areas. First of all, monitoring and managing the impact of the fee increase under Senate Bill 815 to ensure licensing revenues remain sufficient to support operations. Number 2, evaluating expenditures and resource utilization, including staffing levels and vacancy management to control cost. Number 3, prioritizing timely collection of reimbursements and cost recovery at present cost, especially in enforcement, licensing program, and other shared services to maximize available funds and cash flow. Number 4, using prudent budgeting and forecasting to avoid overcommitment, which helped deliver under-budget performance and maintain reserves. This achievement is more than just a short-term balance sheet fix. This signals a structural shift in how the Medical Board of California operates financially, from relying on loans or emergency funding towards a self-sustaining model supported by stable fee income, controlled expenditure, and disciplined operational management. Further, it frees up bandwidth to focus on improving board operations, enforcement oversight, and service quality, rather than being consumed by ongoing financial distress. Media relations and external communication. Since last board meeting through early November, board staff had opportunity to present to various organizations and assisted in e-blasting important information to licensees. This concludes my report, and at this time, myself and my executive team are ready to answer your questions. Thank you for the opportunity.
Thank you, Mr. Varghese. And I guess I just want to double click on the board's financial condition and what an extraordinary, first of all, how much work went into getting us to the place where we've paid off those loans from the Vehicle Inspection Repair Fund of California. And, we used to at these meetings spend a significant amount of time talking about our financial condition. And I thank you for all of your hard work and all of the hard work of the staff at the medical board to get us to this place where it's noteworthy, but it's not a topic we have to spend a lot of time thinking about or worrying about for that matter. And I really appreciated what you said, that it also frees up staff's time to work on more important priorities. Other questions, comments from board members about any of the reports? All right, we're going to have a lot here. So we're going to start at the end here. Dr. Ayala Rodriguez.
Just want to start briefly that it's like very exciting to see how the docs portal continues to be more utilized, more engaged, the stakeholders and everything. That's like great news, because I know that IT, licensing, everyone has worked so hard in creating engagement with the portal. So no questions about that, just creating that awareness that that's such a great job, great engagement. Also with the discipline coordination unit, I think that it's great, like how many cases like we're able to catch up. That's a huge increase, like from the 406 to 137. And also like the timing of some of those cases also improved greatly. Like that's great job from that. And I do acknowledge there's a lot of great changes in the budgeting, in the board financial condition and everything. I just have a quick question with Reggie. So on fiscal year 2024-2025, the expenditures were like 75, but on this new year, we estimate that it's going to be like 83. That's like about like a 10% change in operating cost. But I kind of heard that there's like a decreasing staffing vacancies and things like that. Where do we see the 10% increase in expenditures come from? Is that like inflation? Is that like the changes in contracts with legal fees? Like, do we have like a rough idea of that 10% change in operating cost? Yeah.
Thank you for that question, Dr. Rodriguez. So 24-25 fiscal year is already closed, and that the numbers reflected there's the actual expenditure. 25-26 is the budget year that we're currently on, so that's a budget amount. So we're only in the we just covered the first quarter. So as we go forward and we close the books, even though we budget, so we would, based on the fiscal operations and management of our expenditure, we would come, our goal is to come down. But yes, we do build in the inflation and all that into the equation there. And when we build the budget, it's always before we know what the new insurance cost that's going to go into effect January 1 and all that. So, we will continue to monitor that, and if there's any necessary. But so far, the track record is we always come under the budget. Yeah, thank you.
Dr. Thorpe. Thank
you, Madam President. I have questions in a couple of areas. Mr. Hawking, in licensing, previously, as we were making the transition from PTL, from the old style of graduate licensing to the PTL licensing, we had a very almost disastrous period of time where people couldn't get licenses, and we were very far behind. And I really appreciate all the work that's been done to update the system and to get us online. Are we still seeing that same? Yeah, because we were seeing at the time we were seeing periodic, dramatic increases in requests for licensing, and I guess my question is: are we able to anticipate that now? Is it a smoother process now? Are we having that same traffic jam kind of problem that we had before?
So great question, Dr. Thorpe. I would say our outreach has been very successful at getting that information out. And just this past year, it shows how well our outreach has worked. You may have seen earlier, like maybe August, September, our processing times increased. They got up to about 52, 53 days. Well, the reason being was the outreach is asking for PTL applicants to apply early. So we got a tremendous amount of applications that came in the late part of May and all through June, which these applicants now have 180 days to be licensed. So we would rather get all those applications early. And yes, it did increase our processing times, but now we're ready. Our processing times are back down to about 28 days. And now we can focus on the few that are applying later so that we can get them their license without any interruption in their clinical practice within 180 days by the end of this month.
Great.
Yeah.
Thank you. And then I had a question for Ms. Smith as well. Maybe it's just it appears to me when looking at the timing for average days to initiate a complaint and average days to complete complaints in the central complaint unit, that all of a sudden we're seeing significant increases in time. And I just had a question, what seems to be the reason for that?
It's multi-factor. So I've spoken before about staff, new staff coming on board. There's a large learning curve. Also, sometimes the obtaining information, it takes time, to get a release when we need it from the consumer, and then we get that and we're requesting records. That can take time, and in some instances, we do have to request assistance to subpoena those records. Additionally, with the complainant liaison unit, we aren't where CCU used to close the complaint and the aging would stop. That is still aging when it's referred to the complainant liaison unit as well. So that is adding somewhat to that.
Okay.
Mhm.
It just historically, there's a significant increase in the curve. So maybe that combination of new staff and the complainant liaison unit
Yes.
addition may be part of that.
And additionally, with transitioning to new processes,
Yeah.
change. Some people are more,
Yeah, I mean, otherwise,
Even a little bit better,
I agree with Dr. Ayala Rodriguez, very. And I would just comment, when I first came on the board in 2019, I mean, it was a disaster. And I mean, the finances were a disaster. And we were constantly, from month to month, not knowing what was going to happen. And so it's obviously the leadership for Mr. Verghese and the board leadership as well, paying attention, and I appreciate not having to be anxious about it. Thank you.
Any comments, Dr. Tolbert? Ms. Remke?
I just have a quick question for the executive director on the budget. I realize it's a really small portion of the overall budget. I'm just curious about the temporary positions and what the scope of that is and why it's been increasing year to year.
So you're referring to the expenditure projection report, the 3 months versus temporary positions. So I just have to look at that again and report back to you on that one. I don't have a
Yeah, that's fine. I should have
answer on that one right now.
alerted you. I was just
Sure.
reading it over while you were talking. And I just noticed on page 5 of your report how it's increased from 425,000 to 854,000. And I'm just kind of curious what that encompasses.
Yeah, some of
but
those
you can get back to me.
the descriptions listed, it's a rolled up description that will have multiple subcategories underneath that is not displayed there. So, there could be 1 or 2 line item budget that probably going over. So I have to look at that and report back to you. Okay, thank you.
Dr. Tsai?
Thank you, Madam President. I'd like just to echo the commentaries from before that serving on other state boards, the sweet spot for reserves is about 6 to 9 months. And so we're headed in the right direction. So excellent job. With our IT, I know that we're heavily based on iOS system, and the print at home medical license is a downloadable PDF file with a QR code on top, and you can take a pair of scissors and trim out the outlines and stick it in your wallet. Now, is there plans to update that to include it in the medical board app or as a downloadable Apple Wallet card so that we don't have to take a piece of paper that may fade over time sticking it in the wallet.
Yeah, we've actually done a proof of concept on the wallet card. So we wouldn't integrate it into the app itself, but yeah, right where you download the PDF, you could download the wallet card version too. So it's
excellent.
Just so many other projects going on. That's on our list to do, but
Wonderful, thank you. For licensing, I know that the board has an updated, almost a weekly update of the processing times ranging from 21 to 28 days after your application is complete, not from the time you submit your application to issuance. And then there's a quality assurance review. Are those the quality assurance review times are usually 1 to 4 days. Is that included in that total time, or is that separate from that total time?
That is included in the total time.
Okay. So when somebody asks me, oh, how long does it take to get your license? I can say from the time that it is complete, then it's 21 to 28 days, depending on the category. Excellent. Thank you so much. And lastly, for our enforcement director, I have colleagues who are interested in the expert review or medical consultant program. They asked me, what's the difference? And I said, well, you sort of review. And then I went to the medical board and I looked at it and I said, well, I think they're about the same, but can you sort of clearly delineate what, compare and contrast what the differences are?
The consultant or the expert?
Yeah.
Yes. So the medical consultant program is usually utilized by the central complaint unit. So these are upfront cursory reviews. These physicians that are consultants, they do not have to testify at hearings.
Okay.
That is also the difference. The expert reviewer program, those experts, they may have to testify at hearing on cases that might go to in front of the Office of Administrative Hearings to charge a doctor with discipline. Yeah.
So they're not mutually exclusive. You can sign up for both.
Yes, you can. Yes, and the pay rates are also the difference.
Very good.
Yes.
All right, and that concludes my questions. Thank you.
Thank you, Dr. Tsai. I'm just looking. Dr. Mahmood, I'll just keep going in order.
I'm just going to have a brief thing on budget. Thank you so much. I think we are finally moving in the right direction. Do we have anticipated time? Then budget will be neutral. We won't be in any debts. And do we have planned 5 or 10 years from now that when we are neutral or accruing something that if we go into some rainy days, we'll have instead of going to the huge debts and taking loans and kind of stuff? I think this is the best time to plan for that.
Right. We don't have any current debt. Completely everything paid off. Like Dr. Sai mentioned, the other boards have 6 to 9 months of reserve. We have a limitation of 4 to 6 months. I mean, we tried to get it up to a year, but we didn't get that passed through the legislation last time. When you look at the size of this board and the future liability and contingent, or it's always good to have the tailwind, right? When you are flying, so you can manage the fuel efficiency of our flying machine here. But we don't know when we're going to get that headwind, and that's when our fuel efficiency is going to go down. And 4 to 6 months of reserve is nothing. That can evaporate in a minute. So we need to continue to ask the legislators to increase our months in reserve to at least to equal the other boards, or just completely eliminate it. My preference. I mean, we can better manage, and I know there's a lot of options and there's a lot of constraints, but I think we always at this point we are okay, we are fine. But I still think feeling safe that we have 4 months of reserve is not good, because we have a lot of projects coming up in the future, like physician health and wellness program. All those things are the future projects coming up. So we need to keep in mind that we need to have good fiscal operation to preserve our funding level and meet those future projects when we are entrusted with that. So we don't have to say, well, we don't have the money to embark on those projects. We can manage that.
Okay. My follow-up question is, I wish and hopefully it get to the point where you have 6 or 9 months reserves and all that stuff. Is there anything in the future plan to act a little different and cut down the physician's license fee at all at some point? Or it's too hard to ask that?
I don't know the answer to that right now, and maybe we'll cross that bridge when we come to that point.
There is not a day go by, I'm asked by doctors that this board is extremely expensive. People, not just in the state, people who are out of state who wants to keep the licensing, that might be a helpful thing that people who want to keep the license, they will be more interested and revenue will stay the same, but just wanted to bring this on record. Thank you.
This is more a suggestion for Ms. Charlene Smith. I know right now with Dr. Sai asking about the need for recruiting more experts or consultants. I feel like prior to joining the board, I hadn't really heard about the need. So suggestion was maybe reaching out to different medical societies throughout the state, making them aware. I'm in the Central Valley, hadn't really heard about that. So just sharing that, I know it's mentioned here that it's going to go out to the newsletter, but I'm not sure how many physicians are subscribed to this. So wanted to point that out.
Thank you. And I failed to mention in my report that our manager with the expert review program did attend the House of Delegates to do some outreach. And in the past, in the program, we have reached out to professional licensing associations, as well as deans of medical schools, to try to put it out there. We will never tire of making those efforts, but I'm sure in the year coming, we'll be doing more outreach and putting more information out there about both programs. Thank you.
Thanks, Mr. Watkins.
This is also for the chief. I see on the complaint liaison unit, interviews conducted 856. That's a lot. So can you give me a sense of, was all of that exit interviews? So basically I'm closing the case and I'm just listening to you. Is that the majority of the cases? Or what is that split between this is the final exit interview, so there's a number, and then there is, oh yeah, we're looking for more information or clarifying questions, because those are kind of the two arenas that I assume you'll be playing in.
So I'm going to answer first with CCU, the Central Complaint Unit. So from the get-go, we want the consumers to provide us as much information as they want us to know about that's relevant to their concerns. And we request what we determine is necessary based on what information is provided. So once that goes through its process of review and the medical consultant review, and if the medical consultant opines that there's not a departure to warrant further investigation, that is what triggers it referring to the complainant liaison unit. And so the questions are to, again, give the complainant the opportunity to tell us what they want us to know. We might discover maybe since they filed their complaint, there's new information. So that's the opportunity for them to share that with us so we can determine, does this need more review? Or have we reviewed and considered all information that is relevant to the complaint? And if so, and there was no violation, we'll close that.
So at that I just want to understand that it's kind of important. So at that interview, it sounds like we make that determination. If there's no new information and the reviewer has already seen, we're going to close the case, then it is in fact, exit interview, right? It comes in as a neutral interview, but it falls then in an exit interview. Because what I would like to see, just for me, because it will inform us better.
Sure.
How much of that ends up being an exit interview? Because in the instant that it's all just exit interviews, then what's the point of the complaint liaison unit? You see, then we're putting time on the table in the aging of the case where the thing is just going to run its course the same way. I'm just thinking
Sure.
of solutions in that space.
Sure. And, we don't know what we don't know.
We don't.
So it's really, as the stats show, it's important and it's great. And we're very excited about it. It is new. So of course things can change and it can improve. Absolutely. We don't consider it an exit interview. We consider it another opportunity to communicate and reach out to those individuals because they've come to us for their hard time, whether it's them, their family, whomever. And we want to make sure we have everything to know that we've dotted all the i's and crossed all the t's and go on, to make that final determination. You're welcome.
Dr. Yip.
Thank you. A few things actually scattered because all the comment make already. We'll start with Ms. Thirst. Following line the complaint follow up, which is good. 52C, 5C2, 196 current cases attempt to contact complainant who did not respond. Do you send them another note or do you just close the case at that time?
You're talking about the complaint, the 196
Who
and the
did not
complaint
respond to
liaison
the prior medical record?
Yes.
Yeah.
So in the central complaint unit, if the complaint alleges patient death, we have the statute allows us to go forward and make our attempts to get those releases and obtain the response in the records. In quality of care cases where it's not involving the patient death, in the central complaint unit, we're making 2 attempts to contact the consumer to ask them to complete and return those releases, and they haven't. So just to add another check and balance, now CLU is referring it, because if it's a quality care complaint within our jurisdiction, it has to go to the complainant liaison unit per the statute. And so we're making that additional, so that's our 3rd attempt to contact the individual to ask them to provide us the release. And if complainant liaison unit is successful in reaching that consumer, then they will refer it back to the the central complaint unit to open that up, send the release, and go forward.
Great, thank you.
You're welcome.
And next question about 5C6, the table 25-26. Is that 6 months or 1 year?
I'm sorry.
Statistic.
Give me a moment to pull my, I'm sorry, which table was that? 5C6?
5C6 is actually the same as later 5C13. The statistic average HIU investigation days by case type, year 25-26. Is that 6 months, 9 year, 1 year?
I would have to defer to Ms. Whitley on that. That's a health quality investigation unit stat.
I'm just curious, the days drop, like
Yes.
conviction of crime drop from 381 days to 39 days, and then there's improvement in some of those, like misconduct or self-abuse, some improvement there. So I'm not sure what is 6 months, 9 months, big drop there. So, and the other question is about expert. I myself have sent email to contact like UCI, Loma Linda, USC over the years, and the dean's office always excited about it, and then nothing happened. In the past, I also have made suggestion, maybe the president or the executive director with the letterhead, Medical Board of California, sent a formal letter requesting the squad program. It's interesting to see how the interest in the public is that it seems that nobody want to be involved, and even Reggie did a lot of outreach now to give grant rounds and all that. And the most interesting is that older physicians tend more attention. The younger physicians tend not to even care. I think we probably need to do a little bit more outreach. Maybe send some formal letter. And the other thing is about expert. On and on, we hear story about certain experts not performing. So with the contract CMA system is a reminder if the contract's up or not. Is there a scoring system? I heard from some of the DAC, actually they have like a list of good and bad experts. I'm just wondering, do we keep the bad expert there, or do we identify who are the good ones that we should engage more?
We do monitor based on feedback from, our users of their services, as well as the Attorney General's office. And another project that we'll be working on for contracting is to try to eventually make that automated versus manual person doing. So it's a constant battle to find the experts sometimes, especially in some of those really, specific areas. But we are always striving through outreach, through publications, everything, to try to find them. But we do internally have information that, we do get evaluations, and we utilize that feedback to determine if, there's do we need to have that expert go back and redo components of the training if they've already completed, or should they do the refreshed, revamp, self-paced training that's been implemented?
Great. I do feel you have a passion for your job, which I'm very honestly, I'm very pleased to see. And also make a very truthful comment about some of the changes brought by the public. Do you have a wish list of what we can do, the legislature can do to make your job more successful and more helpful?
I just think we always have to think outside the box and think about things. And I think that, like I mentioned, the CLU, the Complainant Liaison Unit, I think that is really huge. And I'm hoping that the advocates feel heard and the results they feel, I am passionate about the work I do, the board I work for, the people we serve. And so I will always think of ideas. I will do my best to work with my leadership and, put it out there like, hey, what about this? What about that? So
We're here for you.
thank you.
So the last thing, we have quite a few new board members, so maybe I can ask Doug to explain the difference about 2113 and 2168, those faculty permit.
Sorry.
So
You want me to
like,
explain the difference between?
yeah, 2113, the medical school faculty, I know some of those need to be like on faculty for 7 years before they can get licensed, before they can get their board exam and post certification. And whereas 2168 is a special permit that will not be eligible license after the employment. So maybe some explanation to the new board members.
Sure. Yeah, the 2168 is a special faculty permit. This allows individuals from outside the country to come here and join some of the medical colleges here in California to provide medical services, and it's a wonderful program. And the 2113, that's also for foreign medical individuals to come over and be able to practice at the medical communities here in California colleges.
The reason I bring it up, maybe you can, the staff, educate us in the future, how can we make changes to make those qualified physicians more accessible to come to this country and stay in the country, because we do have a shortage of physicians in our specialty. Thank you.
Yeah.
Any further comments or questions from board members? Dr. Tolbert.
This question is for Ms. Smith. In terms of looking for expert witnesses and our ability to maybe help with that, is there a list of materials, outreach materials that we have access to, or that we could utilize to help in terms of recruitment, or is there a process for that?
We do have outreach materials, which are needing updating, but we're working on that. But yes, we do have materials that we'd be happy to share with you. Yes. The application and information is on the website. There's a dedicated page under the enforcement for the expert reviewer program. And so that's a good resource.
And would you, in terms of when the materials will be updated, would it be better to wait, or would it, or what would be your recommendation?
It provides sufficient information now. It's a trifold brochure, but we have a great team. We have some vacancies, but we have a great team of staff who are available to answer questions.
Okay, thank you. Thank you.
Mm-hmm.
Additional comments, questions from board members? All right, seeing none, let's open it up for public comment. Are there any commenters in the hearing room? All right, seeing none, Sean, if you could open it up on WebEx.
Yes, if you'd like to make a public comment on agenda item 5 here, please go ahead and raise your hand or type anything in that Q&A window. First up here, we've got Michelle Montserrat Ramos. Oh, I'm sorry. There's one in the room.
All right, you can come up.
Sorry, Michelle, just 1 second.
Do you have a comment on this agenda item that's coming up? Yeah. Correct. Thank you. We'll go back to WebEx.
Okay, Michelle. Line's still open. Please proceed.
I am Michelle Montserrat Ramos, and I'm with Consumer Watchdog. Thank you for your work on this project, Sean. We look forward to the launch of the Consumer Complaint Tracking Notification System early next year. FYI for the new board members, this project is one of several that our team of advocates pushed through. It's an idea that I came up with years ago and is moving forward thanks to Dr. Yip. Without Dr. Yip's support, the public would not have this future new tool to use to effectively communicate with board staff. Regarding the complaint liaison unit, in the enforcement report, you refer to 1,258 complainants who were invited to participate in interviews. Throughout this report, you refer to quote unquote interviews. The policy change that we as a team advocated for and successfully gained through the Sunset Bill was for a required interview before a complaint is closed. To refer to these interviews before you close a complaint as merely interviews is misleading. I know this because I witnessed one of these interviews. Please explain to us the different interviews this unit conducts and how many of the 856 interviews were the required interview before this board closed a complaint. I witnessed and participated in one of these interviews and specifically asked the CLU rep if this was a final interview, and she told me no. I asked her 3 times, and she told me no 3 times, yet the family received a closed complaint letter 3 months later with no offer of a required interview before their complaint was closed. This is a family who advocated for these changes. This leaves me wondering how many other families have had a similar experience. Thank you.
Thank you for your public comment. And next here we have Rob Gordon. Rob, you should be receiving that prompt.
Yeah, hi. I wanted to comment first, which something I've said before about the online complaint form. That is entrapping citizens. They don't know that you take their information and hand it over to the physician's attorney team. You did it with me, and it was used to file a workplace constraining order with more lies than I have ever seen in my life in one place. But I guess I'm not supposed to mention his name, even though it's, you're not investigating it again. But he's the chief of psychiatry at Family Healthcare Centers of San Diego, which is a federally qualified health center. Another thing I'm not sure if I'm allowed to talk about. So I want to say that just briefly on the iOS consumer complaint tracking system, it's possible that has some use for licensing, but if you're tracking, if somebody's trying to track a complaint on that, that is extremely rare for it to go all the way through. So I'm not sure what it does. So I want to mention that really briefly about your physicians, the expert reviewer program and the consultants program. Extremely important. The most serious issue I've ever had in my life was the false accusations that were made to me about me by Family Healthcare Centers of San Diego. Outright lies. I never got a call. The only call I got was when they called to dig up dirt on my real psychiatrist, who's a pretty good guy. He made some mistakes. He was a pretty good guy. Totally bogus charges against him. Never in California's history has a California psychiatrist been charged with the death of a patient. At least not in the locked, somebody who's not in the locked ward. Happened once in a locked ward. So that's a very, very public interest. We need to know why that happened, what the decisions were, but it's very smelly what went on there. But 100% of the complaints, of the investigations, if they did not contact the person who made the complaint, then it's totally a bogus investigation. It's look in any police manual. You have to interview the victim. If you didn't do that, which I never was, you flushed public money down the toilet. It's totally worthless. As far as the budgets, you guys should already know that. You've got control of the levers. You can dial things down and make your debt go away. But if you investigate less, process fewer complaints, or investigate longer, or whatever, you just, numbers are related to each other. The other thing about your president, I have an open complaint, about your managing director. I have an open complaint about him. You simply ignore them. So I don't know if he's above the law. Even the president is not supposed to be above the law, but he apparently is. He came up with a new psychiatric disorder for me called a general personality disorder. In all likelihood, this was a sloppy job that was embellished. Go ahead, say whatever you want. It doesn't make any difference, but that's the way. I'm done. You're not going to listen anyway. Go ahead.
Thank you for your public comment. Next here we have Tracy. You should be receiving that prompt.
Good morning. I am Tracy Dominguez and I am from Bakersfield and I am a volunteer with Consumer Watchdog. The Complaint Luce unit, I need clarification on the distinction between the interview and the required interview that must require before closing a consumer complaint. It is essential for families like mine who have passionately advocate for mandatory interviews prior to the closing of any complaint. To understand this difference, furthermore, I would appreciate insight into which type of complaints are referred to the complaint unit, Lizzie unit, and which are not. I understand that the CLU received 1,532 cases and reported inviting 1,258 complaints to participate in the interview with 856 interviews conducted. I hope these interviews were required interviews that take place before your complaints are closed, as this is a purpose of your unit. Our primary aspiration is to assure that the policies we fought so hard for is not only upheld but become a practice. It is imperative that families whose complaints are closed are provided the opportunity for the required interview for them to advocate effectively for their complaints. For their observed, this is not always happening. It is vital that each family member whose complaint has been closed is offered the opportunity to fight for their complaint. The probation unit, we have brought it to this board's attention as urgent concern regarding the probation monitor in the Central Valley. The board members that specifically require that the board staff address our concerns and share that at the board meetings, yet they are not transpired. With these vacancies in the probation unit, there are 560 doctors currently on probation. How can we assure that the physicians on probation in these understand the areas they're receiving the oversight they need? The OBMC probation monitor offers the public and their board details insight on how to supervise doctors on probation, including the disciplinary actions linked to the substance abuse doctors. In other physicians, regulatory board members can provide such transparency. Surely this board can do the same. Let's strive to uphold standards. And I also wanted to say that we should consider saying that the Lizelle unit is confusing families and we do not feel heard. We do not feel heard and it's not working. Thank you.
Thank you for your public comment. Next here we have Maria Ibarra Navarrete. Should be receiving that prompt. If anyone else would like to make a public comment on agenda item 5, please do so by raising your hand. Good morning, Maria. Oh, let's try you one more time. You should be receiving that prompt on your device to unmute.
Hi, yes, good morning. My name is Maria Ibarra Navarrete. I am from San Jose and I'm a volunteer Consumers Watchdog. This is for the probation unit. We seek to gather vital information regarding licenses placed on probation, which we enhance our understanding of the underlying issues involved. Specifically, we would appreciate clarity on the following points. 1, how many of the licensees on probation were associated with substance abuse? 2, for the 2 licensees who faced probation alongside suspension, what were the causes of the suspensions and were they related to substance abuse in any way? 3, regarding the 8 probationers who voluntarily surrendered their licensees while on probation, what was the reason? 4, among the 9 citations issued for probation violations, how many stemmed from substance abuse, failed biological fluids, or instances of skipping tests? 5, what factors led to the instances of the 3 ceases practices orders due to probation violation? Understanding not only the numbers, but also the specific causes of these disciplinary actions will help us identify emerging trends, enabling us to better address these critical issues. How are the 560 licensees currently on probation being effectively monitored? And three vaccines, how can the public be confident that probationary doctors practicing in these areas are receiving the attention they require? The OMBC Probation Monitor delivers comprehensive updates to both the public and the board, detailing how they oversee doctors of probation and whether disciplinary actions pertain to substance abuse issues. If another physician regulatory board can provide such transparency, I believe your board has the capacity to do the same. It's imperative for public trust that we understand how our healthcare professionals are being supervised as their disciplinary orders require. Thank you.
Thank you for your public comment. This time I don't see any additional requests in queue.
Thank you, Sean. Are there any further comments or questions from members? Seeing no one else in the room, I think we'll move on to agenda item 6, updates from external stakeholders. And again, like the prior item, we will take comments after we hear from both DCA and from HQIU. First, I'd like to introduce Lucia Saldivar from the Department of Consumer Affairs. You are a new rep.
I am, yeah. Good morning. Great. Good morning, Board President Lawson, board members, and staff. My name is Lucia Saldivar of the California Department of Consumer Affairs. Thank you all for the opportunity to provide some updates on behalf of the department. Firstly, I would like to join in welcoming Board Member Tolbert to his first meeting. Thank you, sir, for your public service to the board, and welcome. Next, I would like to introduce myself as one of the newest members of the department's executive team. I was appointed by Governor Newsom in October to serve as the Deputy Director of Board and Bureau Relations. Prior to this appointment, I worked in the state legislature, most recently serving as Chief of Staff for Assemblymember Lisa Calderon. I also previously served as her Legislative Director and as an Assembly Fellow and Legislative Assistant in the Office of Assemblymember Jackie Irwin. I'm an alumna of the Hope Leadership Institute program and a member of the California Latino Capital Association Foundation, and it is a pleasure to meet all of you this morning. We are also happy to welcome Shelley Jones to the department's executive team. Shelley was appointed by Governor Newsom as the Assistant Deputy Director of Board and Bureau Relations. She brings 29 years of experience and has been with DCA since 2015, serving in several capacities with DCA's Board and Bureau Relations team and the Solid and Organizational Improvement Office. Prior to joining DCA, she served in multiple roles at the Juvenile Parole Board of the California Department of Corrections. We are so very excited to be serving as your new Board and Bureau Relations team, and we look forward to working with you in our new roles. In other news from the executive team, after 36 years of dedicated service to the Department of Consumer Affairs, Director Kimberly Kirkmeyer recently announced that she will retire at the end of this year. Director Kirkmeyer began her career at DCA as a student assistant in 1989. She also served as the executive director of the medical board before she was appointed by Governor Newsom as DCA director in 2019. Within her first 6 months on the job, she navigated severe wildfires and the start of the COVID-19 pandemic, transitioning the department's 3,500 employees to telework. Director Kirkmeyer would like for me to extend a special thank you for the honor and opportunity to serve as your director for the past 6 years. She would also like me to thank you for your continued hard work and dedication to the department, the state, and the consumers of California. Your work is invaluable, impactful, and integral to DCA's mission of consumer protection, and she knows that it will continue for years to come because of the extraordinary staff at DCA. Next, as we near the end of another year, DCA is encouraging board members to review the list of required trainings to ensure continued compliance. As you may remember, sexual harassment prevention training is mandated for completion within 30 days of your appointment to the board and every 2 years thereafter. On October 27th, DCA launched its new sexual harassment prevention training in the Learning Management System, also known as LMS. If you completed the 2024-2025 sexual harassment prevention training during those calendar years, the new training will automatically be assigned to your LMS account 2 months or 60 days before your 2-year mark. If you have not completed that training, the new version was already assigned to your LMS account on October 27th. You will be able to log in and begin your training. Going forward, the compliance deadline will either be 2 years from the last completion date for those who already took the training, or by December 27th for those who did not. Upon completion of this new sexual harassment prevention training, it will be automatically reassigned to your LMS account. If you have any questions or need assistance accessing the training or LMS, please reach out to us at memberrelations@dca.ca.gov. In addition to trainings to best serve the public, it is incumbent upon all of us to ensure that we are being fiscally prudent in our decisions, especially when traveling for board business. DCA would like to remind its boards and bureaus to make travel arrangements at least 30 days in advance and evaluate if a rental car is always necessary versus utilizing ride-sharing services. Carpooling is also highly encouraged when renting vehicles. And lastly, we are officially in the season of giving, and DCA is honored to join in 2 annual charitable campaigns: the Our Promise, California State Employees Giving at Work, and the State Employees Food Drive. Every year through the Our Promise California State Employees Charitable Campaign, state employees, including board members, have the opportunity to support the nonprofit causes that they are passionate about through payroll giving or one-time donations. These contributions have a positive impact on our communities, and it's another way for DCA to show that it cares for California. Please contact Board and Bureau Relations with any questions or if you would like information on how you can contribute. The State Employees Food Drive is a collective effort to support food banks statewide. Collection boxes for non-perishable food items are available at 5 Sacramento area DCA offices. For those not in the Sacramento area, there are ways to support food banks online through the State Employees Food Drive website. Thank you, board members and board staff, for being part of the reason that DCA's Giving Spirit is helping those in need during this holiday season. Thank you so much for the opportunity to join you today, and please let me know if you have any questions or in need of any assistance.
Thank you, Ms. Saldivar. Welcome to the team. We're
Thank
pleased
you.
to have you part of the DCA team, and thank you for your presentation. I think next up is Ms. Whitley from the Health Quality Investigation Unit.
It's okay if you sit there. Stephanie can come here if you'd like.
I'll stay put.
Good morning. Man, after Ms. Saldivar's introduction, I feel a need to, as Dr. Tolbert is new, just kind of introduce myself too. My name is Stephanie Whitley. I am the Deputy Chief of the Health Quality Investigation Unit with the Division of Investigation. I am a DCA born and bred kid. I started as a medical board investigator in 2001 and kind of made my way over to the Division of Investigation prior to the consolidation. And now I have the pleasure of being over the Health Quality Investigation Unit, kind of returning to my roots, which I'm very happy to be here for about 2.5 years now. So with that being said, I'll do my my statement now. So I'm just so happy to be here to provide an update on the Health Quality Investigation Unit, otherwise known as HQIU. HQIU currently has 11 investigator vacancies, representing a 14% vacancy rate. We have 6 candidates in background, with 2 in the final stages of psychological and medical evaluations. Final clearances are anticipated soon, and we are excited about those. To expedite hiring, we at the division continue to screen new applications for each of our offices with vacancies on a rolling 30-day cycle. In October, HQU partnered with the Health Quality Enforcement Section, our HQE partners, to conduct mandatory training sessions in both Northern and Southern California. These sessions focused on investigations stemming from Business and Professions Code 805. These are the facilitating mandatory reporting cases. Feedback from both the AGO and HQIUI staff was overwhelmingly positive. It was a really great training. Those cases can be a little tricky depending on the facility that we're working with. So it was a great day training. In November, the division hosted a statewide supervisor meeting centered on 4 key areas: personnel management, investigative oversight, leadership, and administrative responsibilities. This training was well received also, and it was really valuable to engage in that face-to-face discussion with our soups and managers around goals and new ideas. HQIU has made measurable progress in our cases over a year old. This improvement is reflected in our updated graphs included in board item 7B. As Chief Smith pointed out, on November 1st, HQIU started the new enforcement collaboration model with the board and the AGO. HQIU staff are extremely excited about the enhanced communication with the AGO while conducting these important investigations, always with the shared mission of consumer protection. HQIU maintains regular morning meetings with board staff and provides the automated monthly reports with case details. And I think that concludes my update. I did want to touch on Dr. Yip's question that he asked Chief Smith too before I conclude that quarter's data, the prior 24-25 was a whole 12 months of data. The 25-26 was only 3 months. And those criminal cases, conviction cases are very tricky because, as you guys are probably well aware of, the appeal process in criminal conviction cases can go years. And you have a couple of those cases because all that time will count against us, can skew our stats significantly. So I just wanted to point that out.
Thank you, Ms. Whitley. Do any members have comments or questions for either of the presenters? All right, seeing none, I think we will open it up to the public. Are there any public commenters in the room on this item? All right, seeing none, how about on WebEx, John?
Yes, if you'd like to make a public comment for agenda item number 6, please do so by raising your hand. Type something in that Q&A window. First up here, we have Michelle Montserrat Ramos. Should be receiving that prompt. Morning, Michelle.
I am Michelle Montserrat Ramos, and I am with Consumer Watchdog. I would like to thank Kim Kirschmeyer for her years of service. I remember Kim well from her days as the executive director of this board. We may not have agreed on everything, but she respected our advocacy. When Kim was the executive director, the second day of public comments not on the agenda was still in place because she understood the need for public engagement with this board. She understood that the public does work and may not be able to participate in these meetings for 2 days. When I was with the California Safe Patient Project, led by Consumers Union, otherwise known as Consumer Reports, Kim would invite us to meet with staff. When we had questions or wanted to work on specific issues, Kim would invite us to the board's executive offices and would have staff present to discuss and work on these issues we brought to the table. Kim led the board meetings, and she would not have allowed for board members to be silenced when they had comments about issues that the public presented to the board. Every board member had the right to comment on an issue and were not silenced when they heard the public's concerns and recommended ways that the board could respond or resolve those concerns. Thank you, Kim. You will be greatly missed.
Thank you for your public comment. Next up, Rob Gordon. Rob, you should be receiving that prompt.
Yeah, hi. One more thing that I've already said, but it bears repeating. 100% of the investigations you have conducted that does not discuss or interview the victim, those are failed investigations. You have flushed public money down the toilet, and you have really screwed the person that complained. I've always want to emphasize the difference when people say you've wasted my time. If it is systematic, you need to learn that word. If it is systematic, it is not wasting time, it is theft. It is time theft. I am 71 years old. You stole years of my life, and I'm bitter and angry about it, very bitter about it. The other thing I want to mention, which was the in the censored meeting in San Diego, I mentioned doctors, the lawsuits that doctors file against the Medical Board of California, either countersuits or somehow they have been treated unfairly by your organization, which I imagine happens to many doctors. Just a few of those lawsuits will wipe out your budget surplus, just a few. And because I was censored, I will be actively encouraging doctors to do that. Anybody happens to hear this, contact me. I will help you. I will do volunteer work to help any doctor who wants to sue the Medical Board of California, because that is the only way, that would be the ultimate in patient care, because patients can't do anything about a doctor. Even if you're wealthy, you cannot sue a doctor. The system is rigged. And if you complain to the medical board, you've screwed yourself even more, because you guys send the information, you guys cooperate with their defense attorneys, and they'll ruin your case immediately. So doctors out there, strongly encourage you to file lawsuits against the Medical Board of California. If you need any help, I've got a tremendous amount of knowledge and information. Something about power people needs to know. Knowledge is power, but power decides what knowledge is permitted. And with the censorship of this board, you're deciding what knowledge is permitted. I am one of the few people who has seen both doctors and patients screwed by this system. I've sat through trials like a monkey in a cage where the people are talking about me, massive amounts of false information and outright lies. So I know how the OAS works, all that stuff. Doctors, please, if you're considering a lawsuit, please go ahead and sue the Medical Board of California. They deserve it. Patients will give you their support. So anyway, thank you for anybody who's listening. Appreciate it.
Thank you for your public comment. At this time, I don't see any additional requests in queue.
Thanks, Sean. We'll bring it back to the board. Any members have comments or questions? All right. Before we move on to agenda item 7, because we've got just a couple items on the agenda, because I wanted to take a quick pulse check here to see if we want to break for lunch and then come back and do 7 and 8, or do we just want to keep going? Okay, everyone's saying push through. We will push through. No food for us. No food, no water. We're going to push through. All right. Moving on. Agenda item 7, discussion and possible action on recommendations from the Special Faculty Permit Review Committee. Dr. Ayala Rodriguez, please.
Thank you, Ms. Lawson. Today I will be presenting 2 recommendations from the Special Faculty Review Committee. Following my presentation, I will be making a motion to approve the appointment recommendations from the committee. The first recommendation relates to Dr. Farsad Pakdel. At its meeting on September 3, 2025, the committee reviewed and discussed Dr. Pakdel's application for a special faculty appointment at the University of Southern California Keck School of Medicine, USC. Please turn to agenda number 7 in your meeting packet for a detailed report on Dr. Pakdel's qualifications. Dr. Farsad Pakdel is an internationally renowned ophthalmologist, oculoplastic surgeon, academic leader, and a clinical researcher with over 20 years of experience. After earning his medical degree in 1993, he completed postgraduate residency in ophthalmology and advanced training in oculoplastics, epidemiology, and aesthetics across Iran, the Netherlands, and the United States, a global pioneer in minimally invasive orbital and lacrimal surgery, orbital decompression, skull-based surgery, and biological therapies for orbital disease. Dr. Pakdel is recognized as a leading authority in thyroid eye disease, orbital inflammation, and orbital fungal infections. Dr. Pakdel has shaped treatment strategies worldwide, including during the COVID-related mucormycosis epidemic. His expertise also spans orbital trauma, tumors, optical nerve surgery, congenital anomalies, and aesthetic oculofacial procedures, and he has founded specialized clinics while mentoring future surgeons. Dr. Pakdel has authored more than 90 peer-reviewed publications and multiple book chapters advancing regenerative medicine, optic nerve repair, biological therapies, and patient-specific orbital implants. His work has been supported by major grants, featured in international trials, and includes leadership in the groundbreaking Advanced Research Project Agency for Health Whole Eye Transplant Project. He has held leadership roles in international societies. He has spoken in over 200 conferences, and he has co-authored global competency rubrics to raise surgical standards. Recruited as an associate professor in the Department of Ophthalmology at USC, Dr. Pakdel will establish multidisciplinary clinics for orbital inflammatory disease, foster school-based collaborations, and contribute to curriculum and surgical training. His research will advance USC's vision science initiatives through projects in biologics for thyroid eye disease, neuroprotective therapies for optic neuropathy, personalized orbital implants, artificial intelligence assisted surgical planning, and innovations in orbital imaging. He will also play a central role in mentoring trainees and shaping the next generation of leaders in ophthalmology. The committee recommends that the board approve Dr. Pagdel's application for a special faculty permit. The second recommendation pertains to Dr. Antonio Amodeo. At its meeting on September 3, 2025, the committee reviewed and discussed Dr. Amodeo's application for a special faculty appointment with the Stanford University School of Medicine. Please turn to agenda number 7 to keep reading about the detailed report on Dr. Amodeo's qualifications. Dr. Amodeo is an internationally recognized leader in pediatric heart failure, thoracic transplantation, and mechanical circulatory support, with decades of experience as a pediatric cardiac surgeon at the Bambino Gesù Pediatric Hospital in Rome, where he has served as the chief of heart failure, thoracic transplant, and mechanical circulatory support since 2010. He earned his medical degree from Naples University Medical School, completed board certifications in cardiovascular medicine and surgery, and he has held a full professorship at the Catholic University of the Sacred Heart since 2012. Dr. Amodeo's pioneering work includes Europe's first pediatric heart transplant from a COVID-positive donor, the world's first pediatric impella implantation via the carotid artery, and the smallest pediatric implantation of a 50cc artificial heart. He has authored more than 150 publications, organized international conferences, and remains active in several professional societies. Stanford has recruited Dr. Amodeo as a professor of cardiothoracic surgery, where he will oversee pediatric advanced cardiac therapies and thoracic transplantation, train residents and fellows, and lead research in pediatric myocardial recovery and next-generation pediatric-specific mechanical support devices. As a director of pediatric thoracic transplantation, he will collaborate across disciplines to oversee surgical programs, regulatory compliance, and innovation in transplant and mechanical circulatory support care. The committee recommends that the board approves Dr. Amodeo's application for a special faculty permit. This concludes my report on the committee's recommendations. Are there any questions?
Thank you, Dr. Ayala Rodriguez. Are there any questions or comments from members?
I move to support.
Thank you.
I'll second that motion.
Thanks. I think we have a motion, a second, and a third, right there. Okay. Any comments from the public here in the present room? Present here in the hearing room. Seeing none, are there any public comments on WebEx, John?
If you'd like to make a public comment on agenda item number 7, please do so by raising your hand. Type something in that Q&A window. Give you a few seconds to queue up. Not seeing any requests at this time.
All right, we'll bring it back to the board. And Ms. Struther, can you please perform the roll call vote?
Dr. Ayala Rodriguez,
Yes.
Mr. Arkatov,
Yes.
Ms. Chung,
Yes.
Dr. Mahmood,
Yes.
Ms. Rimke,
Yes.
Dr. Solis,
Yes.
Dr. Thorpe,
Yes.
Dr. Tolbert,
Yes.
Ms. Torres,
Yes.
Dr. Sy,
Yes.
Mr. Watkins, Dr. Yip,
Yes.
Ms. Lawson.
Yes, that motion carries. All right, moving on to agenda item 8, discussion and possible action on legislation and implementation plans. Mr. Bone?
Mr. Bone.
It's a very short cable. Oh,
Can I have a quick question? I just want to know, do we have no proposed legislation for next year on the agenda? I see none, so I'm assuming none.
correct.
Okay, thank you.
Thank you, Madam President and members. The legislature completed the first year of their 2-year session this past November, and the governor finished signing and vetoing bills in mid-October. Legislature is now out on recess and is expected to resume their session in early January. Next year, the board will take the first step of our upcoming sunset review, which is a typically once every 4-year process of focused legislative oversight on the various licensing boards. Before the end of 2026, the board will be required to approve and submit a large report called a sunset report. That report is responsive to a sizable questionnaire that we can expect to receive from the legislature sometime next year. One of the sections of that report that tends to attract a lot of legislative and stakeholder interest is the portion where the board notifies the legislature of key issues impacting the board or consumers and requests law changes that further our consumer protection mission. Through our prior sunset report, we've been able to successfully advocate for laws, as discussed earlier, that established the complainant liaison unit, have established new or increased fees that fund the board operations and have eliminated our debt, and other changes to our enforcement and licensing statutes. After that report is delivered to the legislature in late 2026, it will be reviewed by them in 2027, and the board will appear at one or more legislative hearings to discuss the report and respond to legislator questions. Also in 2027, a bill will be introduced to extend the board's sunset date and include other statute changes that the legislature wishes to make. There will be further discussion, including staff recommendations related to the sunset report in board agendas in 2026. Moving on to today's agenda, the blue and green color-coded tracker list provides the status of the bills recently discussed by the board. A couple of them were vetoed, you will see, including AB 432, which is a bill that the board supported related to menopause continuing medical education. In addition, I want to point out that SB 508, which the board previously opposed, was significantly amended after the prior board meeting. That is now a 2-year bill that relates to the California Environmental Quality Act. The main purpose of the agenda item today is to review the proposed implementation items for the handful of bills that the board discussed this year that were signed into law. However, before we get to that, we wish to provide the public with the opportunity to make comments on AB 408, which is the board-sponsored legislation to authorize creation of a health and wellness program. There are no updates to share on the bill's progress while the legislature is out on recess, but again, still wish to provide the public the opportunity to share their views.
Thanks, Mr. Bone. So we are going to take public comments from the public, from any board members who wish to comment on AB 408 separately, and then we're going to go through the remainder of the implementation plans. So I know there's at least one person in the room who'd like to comment on AB 408. So if you'd please come up. If you could just make sure to turn on your mic, please. Thank you.
Yes, I'm Kay Funk, a retired physician who moved from Washington State to San Mateo 4 years ago. I'm here to speak in opposition to AB 408, particularly to the physician board members. This model is templated on the Washington Physician Health Program, which has been in place for over 20 years. It's been problematic for Washington physicians, particularly those who become ensnared in this system, but don't have substance abuse issues. And I'm here to speak for protection of drug-free doctors. WPHP, FSPHP, and Medical Board of California representatives have repeatedly called this program best practices and evidence-based, but it is not. I have given Mr. Bone a critique of their research, and in addition to having no compelling evidence of treatment efficacy, FSPHP has never even published their diagnostic criteria. They do have some discussion of their method behind a payment wall on their website. The physician members of this board should demand to see their diagnostic criteria. Going further, FSPHP has 0 published data on efficacy of treatment for any diagnosis other than substance use disorder. But this bill would delegate authority to diagnose and treat all behavioral health disability. In the Senate BPED committee, Ms. Webb reported that the current MBC regulatory process is slow and rather dysfunctional because, and I quote, "we have to follow due process." She claimed that this program would be expeditious, but that is because due process would be swept away. But due process is a constitutional right, even for physicians. On repeated questioning by the senators about, and again I quote, how would the program handle a physician who came to the workplace smelling of alcohol, but had not yet violated the Uniform Standards Act by harming a patient? And Ms. Webb stated that this hypothetical physician would be a voluntary program participant with no public disclosure, and that's inappropriate and a disservice to the public. In contrast, California first responders in that hypothetical situation in which there is reasonable suspicion must submit to drug testing, and then they pass or fail according to objective, metric, and published criteria. That's the right way to differentiate voluntary participation from discipline diversion. And that's the right way to protect drug-free doctors
Please conclude.
from inappropriate and harmful drug treatment and monitoring. So everyone agrees that MBC regulation needs to change, but it needs to get better, not worse. Thank you.
Thank you for your public comment. Are there others in the room that wish to comment on AB 408?
Hello, my name is Lucas Evanson, and I'm speaking on behalf of the California Medical Association. CMA thanks the board and board staff for their continued leadership in working to make this long overdue solution a reality. CMA maintains that AB 408 represents a significant step forward in prioritizing both patient safety and physician well-being, because it is a proactive public health-oriented approach to address physician impairment before patient harm occurs. This approach, as highlighted in the board's meeting materials, has already been successfully implemented in 47 other states and reflects best practices endorsed by the Federation of State Medical Boards. CMA looks forward to continuing to work with the board in the upcoming year as AB 408 continues through the legislative process. Thank you.
Thank you for your public comment. Any other public commenters in the room? All right, Sean, if you could open it up on AB 408 for public comment on WebEx.
Yes, if you'd like to make a public comment specific to AB 408, please do so by raising your hand now. Type something in that Q&A window if you'd like. I've seen some hands go up and down, so make sure it's up if you would like to speak on AB 408. First up here, we have Rob Gordon. Rob, you should be receiving that prompt.
Yeah, hi. Couple things. First, the sunset law. You guys have completely perverted the reason that that law exists in the first place. That means shut an agency down. It's been there long enough. It's outlived its usefulness. It hasn't changed or improved over time. It's a good law. That is what the law is for. You guys have used it as a negotiating tip, that you are just in an eternal agency that exists no matter what. So I'm glad you told us about that. So next year, let's get this thing shut down. Nobody's even considering that. It's not impossible. It needs to be re-engineered. At least go that far. This is doing far more harm than good. It's doing very little good. It is harming both patients and physicians. It needs to be shut down. The second point about the new law, the Physicians Health Program, the caller before the CMA lobbyist made some great points, specifically about drug testing. Drug testing has been weaponized, politically weaponized. I experienced it both at Family Healthcare Centers of San Diego, Federally Qualified Health Center, and at UC San Diego Health, where I am subjected now in retaliation for complaining about the physician who made the false charges against me. I am required to, I'm part of their zero tolerance program, but they won't answer their, they won't even tell me what it is. Even on a California public documents request. So I have what I call the urine test challenge. I will take a urine test. Since the medical board, orders urine tests for other people, they should also take a urine test. My conditions are this. We publish it publicly so we can all discuss what's in those urine tests. And also you guys pay for the full cost of the tests and travel time. Again, you're not wasting time, you're stealing time from people. So let's avoid the time theft situation. But the whole law entirely, are you really going to put everybody through that again? You did drama for like 2 years. You know, we needed a break to get on to the trying to. Some of you want to improve this or to help people. Drop it.
30
It's
seconds remain.
ridiculous. Go ahead. I don't care. Go ahead.
Thank you. We're trying to get the time focused there a little better, but thank you for your public comment. I'll continue to give people 30-second notices too. Next up here, we have Tracy. Tracy, you should be receiving that prompt.
I am Tracy Dominguez, and I am from Bakersfield, California. And I am a volunteer with Consumer Watchdog. Your claim that AB 408 will not lead to a secret program is fundamental and misguided. What other terms could accurately describe the confidentiality? This claim that is this program offers greater transparency than private treatment options is not only laughable, it is deeply misleading. Any doctor who is addicted, whether it's a drug or alcohol, who sincerely wishes to overcome their addiction should easily access themselves to a private treatment program like everyone else, and their participation remains entirely confidential. They should take the initiative to better themselves, ultimately benefiting their patients as well. Yet we recognize that this is not the reality we see today. Moreover, it is simply enduring the state of participants withdrawing to fail to cooperate and report directly to the board. Instead, they will be reporting to designated committee, which determines whether they individually should re-enter into a program or refer to the board. And we all know it's a long challenge to overcome alcohol and drugs. I am concerned because this is happening in Bakersfield, California, my community again. There's a physician who is practicing in Bakersfield and is a head of the department of Kern Medical Center, who is reported to this board for drug abuse. The board offered him an interim order to require drug testing instead of having his license suspended. This is very rare for this, having his license suspended. This is very rare for this board to navigate an intern before an accusation is filed. But you did because everyone knows, I'm confused. Everyone knows, he was a danger to all his patients. Once the accusation against this license was filed, it showed that he used cocaine daily and has admitted to the drug use. He is a doctor that works with pregnant mothers, once again, because you have the uniform standards, which are the tools that the legislation provides you to protect your families. You use them. With this program in place, this doctor would have just slipped into this program, and we would have known nothing about it and his daily cocaine use and addiction. This is the reason why the uniform standard needs to remain in place. In the diversion program, it's currently law requires you to do this. Thank you. My community is hurting. And as a board member from Bakersfield, this should concern you deeply. Thank you.
Thank you, Tracy. Hopefully the
camera
there's a little more visible for everyone. Next up here, we have David Granovetter. Should be receiving that prompt.
Thank you. Can you hear me okay?
We can. Please go ahead.
Yeah, so President Lawson, members of the board, good afternoon. My name is David Granovetter. I'm a board certified addiction medicine physician, having practiced in California for the past 36 years. I've also spent more than 2 decades in physician health and well-being leadership and consultation, and I serve as a board member of California Public Protection and Physician Health, otherwise known as C3PH. and today I'm speaking on C3PH's behalf regarding AB 408. So thank you for the opportunity to comment and for the sustained careful work the board and staff have invested to shape this bill. C3PH appreciates the board's clear focus on patient protection and on building a program that can identify risk earlier and respond more effectively. C3PH supports the core structure of AB 408 as a confidential physician health and wellness program adhering to national best practices, administered by a qualified independent entity, and with defined pathways for reporting to the board when patient safety requires it. We believe this approach can reduce harm by moving physicians into evaluation, treatment, and monitoring sooner before matters escalate, leading to patient harm or to further disciplinary proceedings. C3PH is ready to continue to communicate with the board and staff on specific language that will achieve the goals of strong patient protection and the health of our California physicians. Thank you again.
Thank you for your public comment. Next up here, we have Rebecca Marcus. Should be receiving that prompt.
Great. Thank you so much. Good afternoon, board members. My name is Rebecca Marcus. I am a lobbyist for the Consumer Protection Policy Center, CPPC, at the University of San Diego School of Law. CPPC is a nonprofit, nonpartisan academic and advocacy center at USD School of Law. We have examined and critiqued California's regulatory agencies for over 45 years. The meeting materials provided do not adequately inform the board on the legislative committee's public debate on AB 408. Members of the Senate Business Professions and Economic Development Committee were hesitant to pass the bill to the Senate Judiciary Committee. Their concerns were primarily related to the board's budget, staff shortages, and most importantly, the inclusion of doctors who have constituted unprofessional conduct and violated the Medical Practice Act by being voluntary participants and confidentially protected in this proposed program. Specifically, Senator Menjivar posed pointed questions regarding whether a doctor, in lieu of discipline and after a complaint has been filed, would be considered a voluntary participant and granted confidential status. Even the president of the CMA acknowledged the need for further work to address this specific issue and expressed agreement that the bill's language should be revised to provide the necessary clarifications. While providing the necessary vote to advance the bill out of committee, Senator Grayson stated that he would not support AB 408 in its current form on the Senate floor. He was voting in favor of the bill in the hope that the author would consider amendments to address the previously mentioned concerns. It is imperative that the board is fully informed of the Senate's concerns to gain a comprehensive understanding of the bill's status. The CPPC strongly believes that AB 408 is a detrimental distraction that does not warrant the substantial staff and board hours allocated to its consideration. The board should instead concentrate on the enforcement challenges identified by the independent auditor, such as the time and costs associated with enforcement proceedings. A program that diverts doctors with substance abuse issues away from disciplinary action should not be a priority for this board. It is imperative that the board refocus its efforts on practical patient protection measures. Thank you for your attention to this matter.
Thank you for your public comment. Next here we have Maria Ibarra Navarrete. You should be receiving that prompt.
Yes, my name is Maria Ibarra Navarrete. I'm from San Jose and I'm a volunteer with Consumers Watchdog. AB 408 does not reduce patient safety risk and does not enhance patient safety. This board keeps referring to aligning with best practices, but you are not stating what those best practices are. Now, if you are claiming that you are adhering to what the FSMB is documenting, well, they may claim their concern is consumer protection, just as you claim in words only, but not your actions. How do you believe that this program will prioritize early intervention? The past abolished diversion program had incredibly low true voluntary participation, and you all know that. Exactly when does a physician conduct become his or her responsibility? You know, and we know that confidentiality and no uniform standards do not draw people into the prior diversion program. You also know that it will not draw doctors into this program either. You know, and we know that disciplinary action, specifically probation, has worked. It has given the public notice of these issues, but you do not want the public to know that their doctors is a substance abuser, do you? That is really the issue here, right? The participants who truly volunteer to participate in this program will absolutely be able to hide their drug or alcohol addiction. We, the patients, have no right to know who is in this program. You, the board, can decide to refer the substance abusing doctors to the program instead of discipline. And now discipline is the only way for any of us to know what is addicted to drugs and who is not addicted to drugs. The only way that substance abusing doctors could not hide their issues was to have to face the review and discipline the medical board. But that's not it. Let's not kid ourselves here. You know that the board, that in this place, it protects consumers and licenses of the physicians, wants to eliminate any consumer protection. We now have and put all of us back at risk. Thank you.
Thank you for your public comment. Next here we have Michelle Montserrat Ramos. Should be receiving that prompt. Good morning, Michelle.
I am Michelle Montserrat Ramos, and I am with Consumer Watchdog. As CPPC testified, multiple members of the Senate Business and Professions Committee, including the chair who voted no, had serious concerns with this bill. Senator Menjivar expressed her concern regarding doctors who are practicing while impaired. Doctors who have already harmed someone are not the only ones who pose a risk to patients. Proponents have said that the bill does not change any requirements if a patient has been harmed. But AB 408 does change the rules if a doctor was caught using drugs or alcohol just short of harming someone. The bill would allow doctors to seek treatment to avoid discipline even if they were impaired on the job. We urge you again to amend your bill to make a clear distinction between doctors who are truly voluntary participants and those who are only in treatment to avoid discipline after a complaint is filed with the board about their substance use. The patient protections of the uniform standards, including disclosure to the board and consequences when a doctor fails a drug test, must be applied to any doctor the board refers to the program. A doctor who seeks treatment of their own accord could maintain confidentiality. The goal of connecting doctors with treatment before their substance use poses a risk to patients is a laudable one, but doctors still hold our lives in their hands. The board has a responsibility to protect patient safety by acting when a doctor's problem has become acute enough to be reported to the board, whether through a patient complaint, hospital disciplinary report, arrest record, or other method. The legislature enacted standards for oversight and accountability to ensure any future diversion program did not expose our families to harm as the last program did. This board is willing to throw those uniform standards away only to claim to use them for physicians with a probation order that includes the uniform standards. How will any future physician obtain probationary orders when the board can choose to refer doctors to the program in lieu of discipline? You claim that you have thrown away the uniform standards for best practices, whatever these best practices may be. Believe me, you already have the best practices. These best practices are uniform standards for substance abusing licensees.
Michelle, it sounds like you've gone far away from your device.
To bypass uniform standards would effectively encourage doctors to seek help early. This program had no uniform standards and had the same confidentiality that AB Front would replicate, and the participation rate was still low. It attracted only about 250 substance abusing doctors at any given time. You claim that the prior program failed because it was underfunded and poorly managed, yet you have no budget for this program and no funding plan whatsoever. You're working hard to go back to the days when you left the public in the dark. This does not work for the public, nor for the doctors and other healthcare professionals who are stuck working with these doctors. Thank you.
Thank you for your public comment. At this time, I don't see any additional requests in queue.
Thank you, Sean. We will bring it back to the board. Are there any comments?
I'm sorry, actually, last second one came in here.
No problem.
Marion Hollingsworth, you should be receiving that prompt.
Okay, can you hear me?
We can. Please go ahead.
Thank you. Hello, this is Marion Hollingsworth, patient safety advocate. 408 is written to protect doctors. There is no patient safety concerns, especially the claims from this board that it does. It allows a doctor to keep an addiction confidential so the unsuspecting patients will agree to lucrative treatments to benefit the doctors and the hospital's finances. The investigator in my complaint years ago said that the purpose of this medical board was to keep doctors in practice for as long as possible, basically on the idea that a bad doctor is better than no doctor at all. When I said I thought their purpose was to protect patients, she added, "Oh yeah, that too," like it was an inconvenient reminder. Please stop claiming that 408 will protect patients when in reality it just benefits the doctors trying to hide their addictions. Patients should go into the OR with confidence in their team, not wondering whether their doctor is under the influence at the time or any other member of the OR team. I keep reminding board members of their mission statement, which is to protect patients above all. That includes the doctors. Please reconsider your stance on 408. Thank you.
Thank you for your public comment. That's the last request.
Thanks, Sean, and thank you for your public comment. Are there any questions or comments from board members on AB 408? Okay, seeing none, excuse me, Mr. Watkins.
I would be curious to see Ms. K. Fung's critique and suggestions that was given to Mr. Bowen.
I received a hard copy, Mr. Watkins, earlier in the board meeting, so I'll be happy to get that to you later. Thank you.
All right, any other comments or questions? Dr. Thorpe?
Yeah, I guess my concern is I totally hear what people are saying and concerns about impaired doctors. Clearly, we do not want to encourage impaired doctors to practice. But currently, impaired doctors are practicing. Today, there is no safety. You have no assurance that a doctor when you go into the OR, there's a doctor it's not an impaired doctor or an impaired anesthesiologist or an impaired hospitalist or an impaired ICU doc. There is no current protection. There is nothing. They're already there. They're practicing currently. This bill is an attempt to give an off-ramp to those doctors who desire treatment to be able to get treatment and to change that reality. I obviously happy to hear, concerns and updates, but this is our best attempt, and maybe it's a terrible attempt. I'm not saying it's perfect, but that is the intent of, I believe, of this board, is to provide a process that actually protects patients by giving doctors an option to get treatment without, we've all said, sexual harassment or sexual issues or patient harm, all those things. Yes, that person needs to be disciplined, but to encourage people to get help before they need to get disciplined, that's what we need to do. And that's what we're trying to do with this bill.
Thanks, Dr. Thorpe.
Yeah, I agree with Dr. Tolp on that. I think the question that I'm gleaning from this is, we assume that it's going to be different if we apply this. But some of the questions that I heard that to kind of piqued my interest was, what are the best practices? Are those data-driven best practices? Or is that somebody that decides this is best practices and then moves it forward? If I see compelling numbers, not just from, I'm talking about people that are for it and the detractors, and I can aggregate that and see, oh, this is worth taking the risk on such a thing. I say go. Right now, I feel like I'm relearning by taking on some, different points of view. And that's all that we're doing. We want more information so that we can if we want this to succeed, we have to have the best information available and amend however we need to do. And that's my opinion. I don't disagree. I just think there's a process. Thank you.
Yeah, excuse me, Dr.
Exactly. I agree with Dr. Thorpe and partially agree with you too. We have some partial data that when you get support, your performance and your performance goes better and your risk goes lower. There are certain situations where you don't have a data. You produce the data. You bring up something and you are a state which has been leader and pioneer in every single thing. And if you're going to be waiting for 10 other states to give you data or some other things to give you data and then say, okay, we're going to follow that, then you are now going to be making a progress. So sometimes we have to look at what the prospects have been done, how support system, how monitoring, how encouraging people to get help is going to help, and take a little step. I am not saying that it's going to completely change the whole thing, but I think at this time, if you go on pros and cons, you will find that there is very strong possibility you will have some people who will get help. You will have some people who will be practicing safer than where they were before. I'm not saying it's going to completely eliminate the risk, but risk will be definitely lower. How much lower it will be, we might create a data which will be a really roadmap for the whole country, our whole world. So I strongly support this.
Thank you. Yeah, if I could,
No.
I just want to, I guess, remind us or kind of reset about where we are at in this process, because this process has been quite a lengthy one for this board, and it was not without a significant amount of input, right? So the bill is going into the second year of its 2-year cycle. It's a bill that we sponsored, I guess, if we're thinking back to its development, a process that began in 2024. Am I correct about that, Mr. Bone?
I would peg that even earlier,
Yeah.
Madam President,
Fair
when
enough.
we started our rulemaking based upon current law for a PHWP, and the board heard a lot of comments and withdrew that. So
Fair enough. So it started prior to that, but in the 2023, 2024 timeline, we did have multiple meetings on this subject where we heard from experts. And of course, as we've all learned throughout the process, California stands almost alone. I think we're one of 3 states. Maybe we're only one of 2 now, because there was a bill pending in another state over the course of the last year that does not have this type of program. So 47 other states have this type of program. We do not have any program. So to Dr. Thorpe's point, we're currently doing nothing about this issue right now, except waiting to receive a complaint from a member of the public and then sending those physicians through our disciplinary process, where, as we heard earlier on in the meeting, can be quite a lengthy, multiple years long process before we're able to take substance abusing physicians out of practice. So the bill is going to continue to work its way through the process. I suspect it's going to be amended again, and that at our next meeting, we are probably going to have more conversation about whether or not we agree with those amendments. The purpose of this meeting today is just an update about where we're at, an opportunity for us to receive additional public comment. But I suspect there will be more to come at the next meeting once the legislature returns to session. And then there's a committee process that's set, or, timeline that's set.
And just to add, there's a bulk of information that are attached to the board's public meeting materials that talk about the data and the information, the presentations that were made. In the agenda item for AB 408, there's a letter from FSPHP where I count 31 references to various other states and studies and reports and whatnot. That provides a lot of the groundwork that's relevant to, I think, what Madam President was just saying.
Thank you. Are there other comments or questions before we move on from AB 408? All right. Implementation plans.
Thank you, Madam President. I'll briefly go through the other bills on the agenda and share the staff's proposed implementation tasks. Bills that were vetoed will not take effect. Therefore, there's no implementation for for those bills. I think there's 2 or 3 that are noted on the tracker chart. As I go through each on the agenda, you'll hear me say that each of these bills will be reported in our next newsletter edition. And what I mean by that is in the final newsletter of each year, we provide brief information about the various bills that I've been tracking that may impact consumers or the medical community. This is often referred to as the New Law Roundup. And the roundup includes links to bill language and legislative analyses for readers to peruse. After reviewing all the implementation tasks, I'm happy to answer questions, and then I think we'll take public comment on the 5 bills in total. The first is AB 489, which prohibits artificial intelligence systems from misrepresenting themselves as a licensed health professional. For this bill, it will be in the New Law Roundup, and we will work with DCA on enforcement codes to track complaints related to this activity, and staff intend to publish a full newsletter article next year to further promote awareness. Next is AB 876, which establishes in statute a scope of practice for certified registered nurse anesthetists, or CRNAs. This bill relates to licensees of the Board of Registered Nursing, not this board, and I do expect that BRN will have a lot of work on their end to further implement the law. Nonetheless, we propose to put it in the New Law Roundup and publish a newsletter article next year to help promote awareness to consumers. Next is SB 160, which is a new bill to the board, actually. This bill includes provisions relating to conducting background checks in various areas of state government, but specifically for this board and inclusive also of the Osteopathic Medical Board, because we have some overlapping provisions of the Medical Practice Act. SB 160 includes language that clarifies our existing authority to require licensure applicants to provide fingerprints for a criminal history background check. The updates in SB 160 are intended to meet requirements of the FBI so that in time, the board will receive arrest and conviction notifications for criminal behavior that's reported to the FBI through their program known as the RAPBAC program. Currently, after we license an individual, we receive reports from the California Department of Justice of arrests and convictions that occur within California. This topic was first raised in 2022 to the board and included in our sunset report that year. This bill will be included in the New Law Roundup, and board staff will collaborate with Cal DOJ to make any necessary implementation changes and ultimately enroll future licensees in that RAPBAC program once it's available. Moving to SB 387, this bill updates the definition of an academic medical center to allow City of Hope to sponsor individuals for licensure through the Special Faculty Permit Program. This bill will be included in the New Law Roundup, and we are already in progress working with representatives of City of Hope to educate them on the relevant processes, and updated information will be provided on the board's website. Final bill is SB 470, which extends until January of 2030 the authority for bodies like this board to use remote meeting options. Specifically, the authority in that bill we use is for that members of our advisory bodies, like the Midwifery Advisory Council and the Special Faculty Permit Review Committee, for them to be able to participate remotely. That concludes the proposed implementation tasks for this bill. No action from the board is necessary. Of course, staff are happy to take direction, comments, or suggestions from the board members, and I'm happy to answer any questions.
Any comments or questions from board members? Mr. Bone? Okay, seeing none, are there any public comments in the room? Sean, how about on WebEx?
Yes, if you'd like to make a public comment on the remaining legislation items, please do so by raising your hand or typing anything in that Q&A window. Give you a few seconds to queue up. Not seeing any requests at this time.
Okay, thanks, Sean. We'll check again. Any comments or questions from board members? Dr. Mahmood?
Just a question on 160 on the background. When we take the fingerprints right now, giving the licenses, when we take the fingerprints right now, giving the licenses, that doesn't go to national data. It's just in California.
We get California and national data at that time. We then will receive what are called subsequent arrest and conviction notifications for crimes that occur within California.
Not nationally.
Not nationally. So crimes that get reported to the FBI, those don't get reported to us in the same way that California-based crimes do. This FBI Rat Back program is intended to address that, and we'll get those future notifications. That program is not ready yet for our inclusion, but we had statutory changes that we were advised by Cal DOJ to make. Took some time to get the language right, work with the legislature and others, and then we'll be working with Cal DOJ in the future.
So we have a questionnaire there when we give the license that have you have any conviction or arrest. We don't trust them. We just have to get the fingerprints and all that stuff. Or, because if somebody's going to lie, he's going to be completely out of the loop.
So I think, yes, so they are required to answer questions truthfully on their application. And then we also will process fingerprints. And then there's a body of law that indicates how far back we get provided information, what types of crimes can be considered. And that all gets run through the licensing process. And my colleagues could probably answer more detailed questions if you had, Doctor, about what that process looks like.
Okay. Yeah, I would have. Thank you.
Yeah.
Any other questions or comments? Dr. Ayala Rodriguez?
My question is a bill not on the table. Is that okay right now, or a bill not
Potentially.
included on the table?
Potentially, if it's on our list.
Potentially.
Yeah, somewhere in our materials.
Yeah, or maybe a future agenda item,
Yeah.
perhaps, Doctor.
A future agenda.
Yeah, or is it's not on the color-coded tracker chart, or it's completely unrelated?
Maybe
Yeah.
3119.
Oh, well, that was actually from a prior legislative session, and so maybe we could talk offline. Or
Much appreciated.
All right. Any other comments or questions? All right, seeing none, that concludes the board's business for Thursday, December 4th. We are going to recess now, and we will be back here at 9 a.m. tomorrow morning. Thanks, everyone.